afternoon, Dr. Archana. Good afternoon. Hi. Good afternoon. Dr. Singhal. Madam is busy.
Hello everyone, and a big thank you for being here today. I am Amit Saxena along with my colleague Dr. Deepika Chabra from Medical Services. On behalf of Jagsonpal Pharmaceuticals Ltd, would like to extend warm welcome to the experts and attendees for joining this web series, Expert Speaks, with theme Women Health is Nation's Strength. Organized by Dr. Archana Verma with Haridwar Obs Gyn Societies and academic partner Jagsonpal Pharmaceuticals Ltd, makers of Divatrone injection Maintane and Divagest range. We would like to present our Divatrone 10 mg tablets, fully indigenized, micronized dydrogesterone, the only brand having 36 months of shelf life. We present you the range of natural micronized progesterone as Divagest. Jagsonpal would like to thank the experts and attendees for joining us today through this webinar. Dear attendees, if you have any questions, suggestions, clarifications, please post it in the Q&A box or chat box. And if you want to speak up, you can raise your hands. Please note this webinar is streaming live on Facebook and the link has already been shared in the chat box. For today's webinar web series, Expert Speaks, I welcome Chief Convener, Dr. Archana Verma, Madam. Madam is President, West UP Chapter of ISOPARB, Vice President 2021-22 FOGSI. I request Ma'am to please kindly initiate this session.
Thank you, Amit ji and Jagsonpal. Today, actually, we planned a webinar for better care of women health of day-to-day problems, where we want to aware everybody so that they can listen to experts and take blessings from the God also, because so many times our day-to-day activity and day-to-day issues are so many, so that is the creating issues. And if we just give few minutes to our patient for counseling and making us aware what to do and how, what to expect, then we will be taking good care of our patients also, and we will be facing less of the litigations also, and we will be getting our women very healthy and making our nation stronger. In this series, we thought that we start with the Haridwar Society, and Haridwar Society is a very dynamic. I am really thankful to Dr. Sangeeta Singhal and Dr. Sujata Pradhan. They are the president and secretary, and they took initiative of joining this and because for the obstetric causes and gynecological causes, these two are the main causes where we can see and we can do work to reduce the mortality and morbidity, and it really helps to take care of the anxiety part also. So today I welcome all my esteemed stalwarts, speakers and chief guests, Dr. Jaideep Malhotra, and guest of honor, Dr. Priya. And let's start with a prayer first.
Ya kundetu tusharhar dhavala, ya shubhravasravruta, ya veena varadanda manditakara, ya shweta padmasana, या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम्.
Thank you. With that, with the blessings of God, now I want to invite our chief guest, Dr. Jaideep Malhotra. Dr. Jaideep Malhotra, we all know that what a wonderful person she is. She is the person who was FOGSI president, and she's holding almost every international, I will say every international presidentship also, and she made everyone aware about how holistically you can take care of a woman's health and what the Adbhut Matrutva will bring to a happiness in the mother's life, and how to give wing, because when to make the woman stronger and feel stronger. She's a one person whose dedication you can see tomorrow, and just now I think she is going to take a flight to FIGO for an international conference, but still her dedication and commitment is such that, and she's this makes us inspiring. So and we have to learn this also, that how to be a perfect person also, to help everybody, and to teaching is something passion of many. Dr. Jaideep Malhotra is one who is such a wonderful person, I think, and so many awards, so many accolades. I think roughly if I say that she is not holding the post of a great Nobel Prize winner, she may be one day. So I welcome Dr. Jaideep Malhotra to give some words of blessings. We all know we salutes to her passion, and we welcome you, Dr. Jaideep. Please say a few words.
Thank you, Archana. Thank you so much. And a very good afternoon to all of you. It's always a pleasure to meet, especially with all this COVID has really taught us now how to meet online. And I'm very, very happy that we are continuing with it, because, there's a lot of convenience and a lot of resource saving, which is definitely required in the times to come. First of all, Archana and the team, congratulations. I mean, I really love the theme of your webinars. Women's health is nation's strength. And I firmly believe this, because we are the pivot around which any family, any society, any nation, or the world actually rotates around. And I'm sure that nothing can move without us. But yes, our health definitely, especially in our region and also in the Latin American, African regions, is very, very much compromised. I'm sure I don't have to actually talk about any of that, because everyone is aware. But what is very important for all of us is to actually come out of our comfort zones and reach out to people. Because unless and until we reach out to people, we are not going to be able to make any difference in people's lives. And this month, I would say the last month rather, I'm sure all of you know that I'm working with the PMNCH, which is Partnership in Maternal, Newborn and Child Health. And June this year in G20, we launched a huge campaign, which is called as 1.8 billion for a change. And these 1.8 billion adolescents or youth for a change is the campaign, because this is the time once from the mother's womb till adolescent is the time which is a foundation laying period for all of us. So if our foundations are laid well, and that does not only mean about nutrition or the growth, but there are many other things. And I'm so happy that today you are discussing cancer cervix, you are discussing about the first trimester bleeding. Now all these areas are in one way or the other connected with mothers and the adolescent health. Now that is something which is very, very important. And 11th and 12th of October, there is a big, huge global forum for adolescents, which is going to take place virtually. So I would really like all of you to join and participate and show our intent that we are going to look after our adolescents in the best possible way, because this is one area which is very, very vulnerable. But if we handle it well, whether it is, nutrition, whether it is emotional or mental health, whether it's immunization, which you are dealing with, there are so many things which we can prevent in the times to come. So I would really leave you with these thoughts. I'm not going to talk much. I actually really have a flight to catch. I want to finish my work also, but I couldn't say no to Archana. She is very, very dear. And also I could not say no because I saw two very special people in the speaker list also. Ashok Rattanji, who was our senior in college, and he taught us a lot. And so my humble tribute and regards to Dr. Ashok Rattan, I know, and he is a very, very committed soul as far as cancer cervix is concerned. And in my own presidential year, we dreamt of doing a project together, and which I'm sure we will definitely be able to finish. And Priya, again, has been close in the sense that here is another one person. You tell something and it is done. And she, again, I have watched her very dedicatedly working towards the cause which she has chosen in her life. So keep the good work going. And I have many other people here who are very close, whether it's Sneha, Pratik, Vidhu, and many more. I can't name all of you, but I can only tell you my blanket regards and love to all of you. And those of who are listening, I would always say that please first practice what you're going to preach tomorrow. So once you do that and practice with not only your families, but with your near and dear ones and people who are around you, I'm sure we will cover a lot of ground. So thank you very much for having me. God bless you all.
So thank you, Dr. Jaideep. And now I welcome our dear, dear Priya Ganesh. Priya Ganesh is a one person who has made this colposcopy and cancer awareness and screening a real word, because in India we are lacking and quite lagging behind, because this if we want to just eliminate cancer cervix elimination, we are thinking to eliminate cancer, and for that we have to do so much of work still, and Priya is helping us. So welcome, Dr. Priya.
Thank you very much, Archana ji. It's always a wonder. It's such a pleasure to be with you. And whenever you have called, it's never no for me. So, and because Dr. Archana Verma was in the last year, was the vice president of my committee. And we really did a lot of work. Dr. Archana ji, if you remember, we had coined that word called as Swastha Sundar Nari, Prevent the Preventable. And I want to thank Dr. Jaideep Malhotra to acknowledge me and the efforts put. So, madam, it is, हम लोग सब बच्चे हैं, आपको देख देख कर बड़े हुए हैं. So, it's like we are following the path which you have created. So, thank you very much, dear friends. And again, why did we coin up that SSNPP project was because when we understood that not many people are talking about CA cervix, it's like not my part of the, not my baby. It's a baby of the oncologist. Why me talk? So like, and it's not my cup of tea. That is something which we understood, and we did a lot of survey. Before even we came up to this, we did a survey to understand the awareness amongst our clinicians and awareness amongst the, the general public around. So the two surveys went ahead to coin this SSNPP program. And I'm very happy that we have almost covered almost 210 FOGSI societies with the cancer awareness drive. And as rightly said by Jaideep madam, that this women's health is nation's strength. And in that comes everything all together is a women's health. It's making up a gamut of it. And in that, the two topics which has been chosen by Dr. Archana ji is bleeding in the first trimester, of course, that goes with the obstetrics, and again, screening with the cervical cancer. And I'm sure The speakers are going to make the best justice to these two topics. And we have with us two senior speakers, Dr. Pratik Tambe and Dr. Ashok Rattan, because I don't know, I know Dr. Pratik, but I'm not much aware of, not interacted much with the senior stalwart, Dr. Ashok Rattan, but I'm sure, as Dr. Jaideep Malhotra has mentioned, he has been the mentor for many. So I wish all the success. And again, before I sign off, I really want to put it up on this thing that GCPR for prevention and management of cervical cancer is on the website now. And that is covering up completely right from vaccination to screening to management and also cancer managements as well. So this is the first time that this GCPR has come up with all together. It's only not pre-cancer, but also cancer. And all my regards to the experts, Dr. Sangeeta Singhal, Dr. Yashodhara, Dr. Sneha, Dr. Vidhu Mudgil. We had a very beautiful time in RCOG. Dr. Monica Gupta, Dr. Kavita, and all the very best to your webinar. Thank you very much.
Dr. Sangeeta is a president of Haridwar Society, and she consulted. She is very busy practitioner, and but because we gave her a very short time to join and be a part of it, and so you can see that we made a very simple CV of her, and she is from alumni of Agra. And I know her that she's doing wonderful job, and then we will like to invite Dr. Pratik Tambe. Dr. Pratik Tambe, we all know, is such a wonderful person, FOGSIan, and he is making people understand the academics. If you think of academics, you know you are talking about Pratik Tambe. So especially on my request, Dr. Pratik Tambe said yes, and he is here to discuss the very, very important and very, very day-to-day problem, because nothing is so simple. We want to listen, we want to talk about big things, but you know, every small thing is first trimester, and the complication in first trimester are very, very important to understand, and how to deal them clinically, so that you know you are doing a good job for the patients. Welcome, Dr. Pratik. We are waiting to listen to you.
Thank you very much for inviting me. It's wonderful to be in the august presence of Dr. Jaideep Malhotra, Dr. Priya, Dr. Singhal, the president of Haridwar Society, Dr. Sangeeta Singhal, and all the other people who have joined despite their busy schedule on this Tuesday afternoon. I'm here to speak about first trimester bleeding, and specifically we try and cover the common things that we all encounter in daily practice, rather than talk about rare things which will only confuse us. And we try and look at the current evidence that's available as far as possible, so that we highlight what is the most updated evidence and what we should actually be doing in clinical practice. A willingness to be puzzled is a valuable trait to cultivate from childhood all the way to advanced inquiry. When we look at first trimester bleeding, I'm pretty sure that right from the very first day when we enter medical college, to our residency years, until today in clinical practice, it still continues to confuse us. It continues to us new bouncers and boogies, if I can use a cricket terminology. And therefore, it's important for us to go about diagnosing the cause of this first trimester bleeding in a systematic fashion. Whenever I speak about a topic, I like to start by asking whether this is actually a practical topic, it is of some clinical significance, or it's there just to fill in the blanks in some conference program. I'm sure you all will agree that first trimester bleeding is something which we encounter day in and day out. It's ubiquitous in clinical practice. It's also one of the reasons why we as OB-GYNs need to be available 24/7, 365 days a year for our patients. Even more so in infertility practice, because many of these patients conceive, some of them will have biochemical pregnancies, they'll have first trimester bleeding, missed abortion, so on and so forth. We'll come to that in just a couple of minutes. If you look at worldwide statistics, it affects about 15 to 20% of all pregnancies. And commonly, empirically, for decades together, more than 40, 50 years in fact, we've treated it with bed rest and what we call empirical drug treatment. So let's question this dogma. Let's try and understand whether this bed rest and whatever medications we are prescribing our patients, are they really of clinical benefit? Do they help in the pregnancy to continue? And how many of these pregnancies will actually reach term? What are the prognostic factors which we should be looking out for? How do we counsel these couples during this difficult period of their life? So the approach to the patient is quite simple, and you need to have a thorough history, including the medication history, especially if the patient has recently conceived with fertility treatment. She will be on a cocktail of drugs. We will come to those in due course of time. You need to have a physical examination. The first speculum to rule out local causes, I put that down specifically because today the first thing we seem to do is put the transvaginal tube without actually bothering to confirm whether there is local causes like an which are actually causing the bleeding. You need to do a vaginal examination at least once to confirm whether the perilous is open or not. The moment it's open, you know that this is an inevitable abortion. Ultrasound is the mainstay of all our diagnostic armamentarium, and finally, you need to admit the patient, and then we take it from there. So, what exactly are we going to treat the patient with? That will form the bulk of today's talk. But before we go there, we need to address a few terminologies which confuse many of us, including yours truly. So, I've just put those up so that we are aware of what we are discussing. If you look at our textbooks over the past 30 to 40 years, various different terms have come into our discussions in research papers as well as textbook chapters, and I've enumerated a few of them which we commonly come across. Early pregnancy loss, embryonic pregnancy, embryonic demise, non-viable pregnancy, spontaneous pregnancy, complete and incomplete abortion are all familiar terms for us. There are some newer terminologies which are now coming that includes pregnancy of unknown location of PUL for short, pregnancy of uncertain viability, PUV as it's called. PUO is not one of those, that is just a play on words. So if you want to look at the definitions as per the textbooks, we need to be aware that these are continuously evolving. Many of these rely on ultrasound criteria. And of course, when we look at ultrasound criteria, you need to be aware that it varies from person to person. Therefore, you need to have a good radiologist with a modern machine and a good scan to be able to look at all these different measurements. And of course, you need to repeat the scan after 10 to 14 days to ensure that the findings are confirmed. So anembryonic is when your ultrasound shows a GSAT with a mean diameter of more than 25 millimeters, but there is no GSAT or embryo. This, in the good old days, we used to call something as in inverted commas, blighted ovum. Of course, you will not see that in modern textbooks anymore. This is in 70s and 80s. Complete abortion and incomplete abortion, we are aware of. Inevitable abortion is when your return loss is open. Early pregnancy loss is within the first 13 weeks. We already know what ectopic pregnancy is. Embryonic demise is something which we commonly speak about, but the key here is that you need to have a CRL of at least 7 millimeters, which commonly is reached by around 6 weeks of pregnancy from the last menstrual period. But there is no cardiac activity. If you find that the CRL is less than 7 millimeters and no cardiac activity, you are supposed to call the patient back after a week or 10 days and repeat the scan and then confirm that this is genuine embryonic demise. We've already talked about pregnancy of unknown location and uncertain viability. For your reference, this is a simple algorithm which we reproduced from one of the recent papers, and I will not sit and explain this in detail because it's self-explanatory. After you have a physical examination and ultrasound, you need to look at whether the pregnancy is intrauterine, whether it's viable or non-viable, and then you take it from there. In 2 sentences, if I can summarize the entire algorithm, that's how it would be. I'll share this later on in case you are interested. Please feel free to message me and I will share this with you. So let's talk a little bit in detail about the ultrasound criteria which are suggestive of an early pregnancy loss. We've covered this in the previous 2 slides, but I'm just reproducing that so that there is good clarity regarding that. If you find that your gestation sac is 16 to 24 millimeters and no embryo, then this is suspicious for early pregnancy loss. If you find that your mean sac diameter is more than 25 millimeters and there is no embryo, this is diagnostic of early pregnancy. In case you have suspicious findings, again, as we said earlier, you need to repeat your scan. And then if it falls into these criteria, then that confirms that there is an embryonic paralysis. Similarly, if you find that the yolk sac is absent, then the yolk sac being absent with a CRL of more than 7 millimeters is typically something which is very diagnostic of early embryonic canals. But if it's less than 7 millimeters, then you wait and repeat those. Again, these tables are well known to all of us. They come to us from the radiology. And again, in case you are interested, I'll be happy to share these with you. You can take a screenshot. So the diagnostic criteria for early pregnancy loss: mean sac diameter more than 25 with no embryo, or absence of embryo with cardiac activity 2 weeks after you find that previously there has been a GSAT or yolk sac. Again, as we said, if the yolk sac is absent with a CRL more than 7 millimeters and no cardiac activity, that is diagnostic for early pregnancy. We often see subchorionic hematomas when we look at ultrasound reports, and the couple is quite worried. Doctor, does this subchorionic hematoma mean that my pregnancy cannot continue? And it's very difficult to answer that way. And by and large, in clinical practice, what I have been saying to them is that if there is a separation of the chorion more than 30%, then by and large, these patients may not have a very good prognosis. It doesn't mean that the pregnancy will not continue, but the chances of that happening are a little higher. I have this paper here which was published in 2019, and this looks specifically at the association between first trimester subchorionic hematomas and pregnancy loss. This has nearly 2,500 women over 3 years, and 400 plus had subchorionic hematomas, but they found that the presence of a hematoma is not independently associated with pregnancy loss. So there is light at the end of the tunnel. Not necessary that if there is a large subchorionic hematoma, the pregnancy will not continue. Again, at the same time, we need to ensure that there is good supportive care that is provided to these patients. Which brings us to the very nicely to asking the most important question. What are the well-known poor prognostic factors which we as clinicians need to look out for when we do our own scans or when we refer patients to a radiologist and they come back with the report? What are the key points that we need to look for so that we are not confused and we give a good, accurate prognostication to the couple sitting across the table? So these are the well-known poor prognostic factors. This is from the BMJ. It's an old publication, but it has stood the test of time and it's very relevant even today. If you find that there is fetal bradycardia, there's a discrepancy between the gestation age and the CRL, MTGSAT, which is more than 15 to 17 millimeters, all of these are supposed to be poor prognostic factors as far as continuation of pregnancy is concerned. We know that low initial beta HCG values and a decrease, insufficient increase, less than 66% in 48 to 72 hours. All of these are something which is not a good sign as far as continuation of pregnancy is concerned. Let's talk now about the most important part, and that's the treatment. For decades together, as we've said, we've empirically treated women either with bed rest or with progesterone, and sometimes both, because we want to cover all cases. But it's time for us to examine whether these are evidence-based, whether they make sense in today's world when we have so many different other medications that are available. There's tranexamic acid, there are styptic agents, there are so many other agents that are now available to us, but these two seem to have stood the test of time. Are they actually evidence-based in practice? The issue with bed rest, as you will see, is that there are studies both for bed rest as well as against bed rest. It's been prescribed empirically since decades. And in India, if I, as an obstetrician gynecologist, tell my patient that bed rest doesn't matter, you can go to work, you can travel, despite the potholes which are there all over Bombay because of the metro construction. He'll say this doctor is mad, he doesn't know what he's talking about. I'm bleeding, I have a precious pregnancy, he's saying it's okay, you go to work. The fact is that if we look at women who are hospitalized for pregnant miscarriage, it turned out that women who are resting still had a miscarriage, and the numbers were equivalent to the numbers of patients who were not resting. At the same time, there's other studies also which show that bed rest does indeed improve outcomes. So it doesn't seem to be evidence based, but it's something which we prescribe to our patients. And let's face it, if we didn't advise it, we would be seen as not doing the best for our patients. The more important question that we need to answer is whether progesterone therapy brings any kind of benefit to our patients and whether it is appropriate in first trimester period. So the FOGSI GCPR, which was published in 2017, says that progesterone is an essential hormone which is required to maintain pregnancy. And later on, until the placenta has taken over this function, which is around 12 to 13 weeks, that role of progesterone is extremely critical. It is required for endometrial maturation, stabilization, implantation, and also to create something which we call as immunomodulation, because this immunomodulation helps the body, the mother's body, to recognize the fetus which is half cell and half non-cell, allow it to implant, and then grow for 9 months. And therefore, the immune response has to be quietened down. This is mediated by something called as progesterone-induced blocking factor, produced by CD8 cells. And this PIDF is an immunomodulator protein, which induces something called as a T helper type 2 cell response. So you know that lymphocytes are of 4 different types. And one of those cell populations is called T helper cells. And the T helper type 1 or TH1 are the bad guys. They are responsible for pregnancies miscarrying. This role is well established in current pregnancy loss, but it's also there in first trimester bleeding, which may be irrespective of whether there has been a good pregnancy earlier or not. And TH2 are the good guys which help in continuation of pregnancy. This is how progesterone via PIDF helps the pregnancy to continue. And one of the first treatments that we prescribe whenever a woman comes to us with first trimester bleeding is progesterone. Now, the $1,000,000 question is whether it actually works in clinical practice. Is it something which we prescribe empirically? And before progesterone was available to us, after the 1970s and 80s, women used to continue their pregnancy just fine in the absence of progesterone. So how does it actually help? Does it work? Now, the fact remains that in miscarriage, whether it's first trimester loss, which is recurrent or non-recurrent, the TH1 cells induce TNF alpha, interferon gamma, interleukins 2, 12, and 18. And all of these are supposed to prevent implantation from happening. If implantation has already happened, then they are responsible for phagocytosing the embryo and causing embryo reduction. If you have a preponderance of TH2, then all the good interleukins come in and your natural killer cells are suppressed, which in effect is done by PIVF. The way to increase PIVF in a pregnancy where there is first trimester bleeding is by prescribing exogenous progesterone. This is what I was saying. I'm going to skip past this. So now let's answer whether it actually works in clinical practice, because this is all very good in theory. So for this, we turn to a number of meta-analyses, a number of scientific papers published over the past 20 years. This is a world-famous paper by Professor Howard Kraft, one of the world's leading authorities on recurrent miscarriage, published in 2012. And he looked at 5 trials, this is a meta-analysis, with 660 women. And women who were prescribed dydrogesterone or oral progesterone had a miscarriage rate of 13%, versus the control group who were given placebo, which was significantly higher. So you had almost 50% reduction in the incidence of miscarriage just by prescribing dydrogesterone when women presented with first trimester bleeding. The typical dose is about 30 to 40 milligrams as a loading dose, followed by 10 milligrams 3 times a day or 4 times a day. In that case, continued till about 13 to 14 weeks. There are authorities who like to continue in the second trimester as well. Let's not get into that controversy. So this is Professor Howard Kraft's forest plot, and this is something which is well known to all of us because we have been prescribing this agent much before even this meta-analysis came out, to be very honest. I've been living it ever since I passed out of medical school. That was in the year 1999. So this paper is from 2012. But it's nice to know that whatever we were doing empirically does in fact have evidence for it, and that we were describing something which is evidence-based and which has stood the test of time. Fast forward to 2018, and this is the American College Practice Bulletin number 200. This specifically looks at early pregnancy loss. That's the reference at the bottom in case you want to look it up and you want to read the original article. It goes about describing clinical and diagnostic approaches, which we've already covered. It looks at specific investigations, ultrasound criteria, and follow-up, which are very similar to what we started off speaking about 10 minutes ago. And then it debates the utility of progesterone and bed rest. And what they say is that progesterone is the best thing that we can prescribe in these areas. In fact, the Cochrane meta-analysis on progesterone for treating threatened miscarriage, which was published in 2018, that's again the reference at the bottom in case you want to look it up, looked at 7 trials with almost 700 participants. And they said that progesterone significantly decreases the risk of miscarriage. We have yet another meta-analysis. This is published in 2017, and they looked at 9 trials, nearly 1,000 women. They looked at oral progesterone versus vaginal progesterone, and to our surprise, it seems that the oral progesterone reduces the risk of miscarriage by approximately 50%. Remember Professor Howard Taft's paper where he said more or less the same thing, but the vaginal progesterones don't seem to be as effective. They are much less effective than the oral progesterone. So the immunomodulation theory that we've been talking about is something which has stood the test of time, and it's been proven for oral progesterone or progesterone. It's not been so effectively proven for vaginal progesterone. Now, vaginal progesterone has the advantages of having first pass effect, but whether a woman who is having first trimester bleeding is going to actually insert vaginal capsules is something which is debatable, especially in India. So I think most of us would favor the oral route, especially in patients who present with bleeding. So these are the forest plots from our article, which I was talking about, published in 2017. Again, they are all clearly in favor of diprogesteron. As far as the last meta-analysis is concerned, this is 2021, very recent, by Kumarasamy and colleagues, the person who worked on the PROMISE trial. Again, they found that progesterone works significantly better. I want to leave you with one very important trial, and that's called the STOP trial. This is a very recent publication in just February of 2023, that's just 6 months ago. And this is a multicentric trial where they administered either progesterone or placebo to women who presented with first trimester bleeding. And to their surprise, they found that women who were administered placebo and they were given vaginal progesterone, there was absolutely no difference, which means that the vaginal progesterone wasn't working. And the STOP trial actually had to be stopped because it couldn't meet the ethical guidelines. After that, during the interim analysis, when they realized that vaginal progesterone was not working, they said, okay, it's time to stop the trial and put these women on progesterone. Just a couple of recent advances. There are certain molecules which we can assay besides the HCG levels, which tell us whether these women are going to have a successful continuation of pregnancy. One of those is, of course, serum progesterone levels, but the other one is the level of PAPE, and that's something which we assay quite commonly when we look at the chances of chromosomal anomalies in the fetus. Out of 428 studies, 8 of them met their inclusion criteria in this paper with a good sensitivity and specificity. And they said that PAPE is a good marker, but it cannot be recommended as an isolation. In isolation for predicting fetal loss, you need to look at other factors as well. You need to look at FOGSI, you need to look at ultrasound criteria. And then maybe when you put all these together and one of these newfangled AI models, if they can come up with a nice, predictive model, then maybe 5 years from now, we'll be utilizing that model in the near future to predict whether we can give a more accurate prognosis to our patient. This is just what I mentioned, that if you look at the serum progesterone levels, in ART incidentally, we use serum progesterone levels a lot, and we look at those specifically to decide whether we are going to do a fresh embryo transfer or not. And here in pregnancy as well, in the first trimester, if you find that your progesterone levels are more than 35 millimoles per liter, then the miscarriage rate is significantly lower. And if the levels are less than 35 millimoles per liter, the miscarriage rate is significantly high. Though this paper has more than 1,000 women, and it seems to be a good, robust data, in India, I don't think any of us use these in clinical practice. Again, as I said, once there is some good AI-based, meta-analysis that happens, and they put together all these different numbers and crunch them and come up with a nice prediction model, maybe tomorrow, few years from now, we'll be able to put that into clinical practice. This is just about acupuncture, where it seems that women have significantly lower bleeding, cramping, and back pain when you use acupuncture and acupressure. So I'll close with a few simple take-home messages as far as first trimester bleeding is concerned. It requires a gentle, sensitive, and caring approach on our part. Bed rest, which we've used since decades, is empirical therapy. There is evidence on both sides of the line to say that it works as well as it may not work. Progesterone is definitely beneficial in reducing our miscarriage rates and giving us better chances of continuation of pregnancy beyond the first trimester. Oral progesterone via immunomodulation seems to confer more benefits than vaginal progesterone, and vaginal progesterone, any which ways, for most of our patients, would not be something that they would prefer. I can tell you from decades of experience. And these are the markers which are now coming. That's the serum progesterone level and PAPA. Maybe if we put all these together, then, as I said, we can come up with a nice prediction model. For decades together, we thought progesterone is the mainstay of treatment. Even today, we feel so, but there is nothing more deceptive than the obvious fact. Thank you, ladies and gentlemen, for this opportunity. Thank you, Dr. Archana Verma, for inviting me.
Good afternoon, everybody, and
Yes,
good
Sangeeta.
afternoon, Dr. Archana. It's very nice, and you were very warm and inviting me for this wonderful session. And I extend my heartfelt thanks to all of you, and thanks to Dr. Pratik for presenting this wonderful talk, and a very clinical, relevant talk, which we all encounter in our day-to-day practice. R is a very small society of 24 gynecologists in Haridwar, mostly private practitioners, and myself engaged in the this public sector hospital. And few of, I mean, 2 or 3 doctors are from this public sector hospital. Otherwise, most of them are private practitioners. And personally, I feel that the adolescent counseling is the most important thing nowadays, and the counseling, because there are so much of information available everywhere in the people are reading, and the mothers are being bombarded with the information about the diet and all fat diets and all sexual education and study materials is available. But there has to be some consensus from our society or from our FOGSI that this has to be the study material. This has to be the presentation which should be presented to in all the schools, right from the 6th of the class, because we used to
अरे
be
ज्वाइन
very
तो करो। अब आया
Yes.
संगीता, अभी तुम देखना सारा फॉक्सी में एक बार आओ तो सही, मिलो तो सही। तुम्हारे तो सब लोग ना प्रैक्टिस में ही बिजी रहेंगे, तो कैसे अब ये जस्ट नाउ आफ्टर दिस यू विल फील एम्पावर्ड एंड देन यू विल गेट इनटू इट एंड you will get everything. You see today's Dr. Pratik Tambe's talk, how wonderfully, how scientific and how clinical value.
Yes. And very crisp and informative. I mean,
You know, acupuncture, he has told acupuncture also, told about what
Yeah.
is you can do with the serum markers also. So many
yeah,
things
it's a
in our
very
patient
relevant
mind.
thing. Yes, yes. But Dr. Pratik, one thing I wanted to just ask you, that the dydrogesterone has come into the controversy regarding its cardiac anomalies in the fetus. So do you have any, I mean,
So I
a
can
word
explain
of
that very simply, that dydrogesterone itself is progesterone. It is not a synthetic or a man-made agent. It's natural.
Yeah.
progesterone. It does
Yeah.
not cause cardiac anomalies. In fact, it does not cause any anomalies at all. If you look at the data which says that it is associated with anomalies, you will see that the background chance of having cardiac anomalies in the population is around 1 to 2%. And the pregnancies where Progesterone has been prescribed since the 1950s are in millions. So if you take 1% also of so many millions, then the number of cardiac anomalies would be at least in tens or hundreds of thousands.
Okay.
And the data does not support that. We don't have 1 lakh children being born with cardiac anomalies over the past 5 to 6
Definitely.
years.
Definitely.
So there is no question of the molecule itself causing cardiac anomalies. By its very nature, anomalies are seen in 1 to 2% of the population, even without any risk factor. Of course, if you have a family history, if there is a consanguinity, then these children are going to have a higher incidence. But when you prescribe progesterone to millions of women over 5 to 7 decades, there should be at least lakhs of children who should have been born with cardiac anomaly. And the drug itself would have been withdrawn.
Okay.
It is sometimes, Sangeeta, I think, because we are from that generation, right? I think 35, 40 years I am using this.
Yes. Recently, yes, ma'am. Recently, I mean, some studies have come, some studies have been transmitted by the companies that the dydrogesterone can cause cardiac anomaly.
The chance that you will die in a road traffic accident is significantly higher than the chance that your patient will give birth to a child with cardiac anomaly.
Yes, definitely. Yes, definitely.
Because India is number 1 in road traffic accidents throughout the world. About 3 lakh people die in India because of road traffic accidents every year.
True, sir. True, sir.
And the number of cardiac anomalies reported from India, I'm sure, is much less than 3 lakhs. Not only per year, but throughout history.
Good evening. Just wanted to ask, what is your take on 17-alpha hydroxyprogesterone caproate, which we routinely give many times during pregnancy? And recently,
so as far as 17-OHP is concerned, it's something which is again prescribed left, right, and center since many decades. Now, those patients who don't want the inconvenience of daily dosing, those patients are not very compliant with taking medication every day. We used to prescribe intramuscular progesterone. It was also prescribed to prevent preterm labor once upon a time. The only issue is that if you prescribe it in the first trimester, especially around 8 to 12 weeks, that is when your organogenesis is happening. And during that period of time, there can be some virilization of female fetuses. That is why it has fallen into disrepute. Otherwise, it's an excellent molecule. It's widely available. It's cheap. It's cost effective. It works very well to prevent preterm labor. The issue is that we have been prescribing it off label even in first trimester, which ideally we should avoid.
Recently, there was some controversy regarding this Prolutone, that it causes more of cancer in neonates and pediatric age group.
I don't think that is the case. The controversy was more regarding the virilization which happens. And that is known because if you prescribe it at the wrong time, you prescribe something which is known to be a steroid around 8 to 12 weeks, you are going to cause some amount of harm to the female fetus and you are going to cause virilization. And therefore, that is the period when we should be avoiding it. Otherwise, it's absolutely fine to use it in the second trimester to prevent preterm labor. Having said that, again, today there are meta-analyses which are coming, which show head-to-head comparisons between oral progesterone, vaginal progesterone, and intramuscular progesterone, that is 17-OHP. And they have found that of all three, the oral progesterone is the one that seems to work best, and the 17-OHP is the one that seems to work least. Therefore, whether we want to offer it to our patients or not, knowing that it is not so effective as the other routes, that is something for us to think about.
Thank you for that, sir. Another comment I had actually, there was a recent Cochrane review in 2021, which says that oral or vaginal progesterone does not increase the live birth rate. It may prolong the pregnancy, but it does not increase the live birth rate. And
That is
even for
true.
those with recurrent miscarriages, if there's no bleeding, progesterone is not indicated because again, it does not increase the live birth rate. This is a 2021 Cochrane.
That's the same Cochrane which I showed. But then the fact remains that the numbers of patients in that Cochrane are less than 1,000. And if you look at clinical practice, if all of us pool our data together, as far as progesterone is concerned, we'll have lakhs and lakhs of patients. And we can also testify that no matter what the theory is, no matter what Cochrane says, in clinical practice, our patients have gone to and they
Clinical
have
practice
delivered.
is definitely different. Thank you so much, sir. Thank you.
Thank you.
Okay. Dr. Ashok sir, you know, he is a chairman, medical committee and quality Redcliffe's this labs. And we know, as Dr. Jaideep said, he
Such a legendary personality and such a small CV. So Dr. Archana has already read that he is the chairman for that Redcliffe committee. And yes, Dr. Jaideep Malhotra has already talked about you, sir. That you were the senior from her alumni. You were the alumni, and of course, we would like to hear from you about the cervical cancer.
So good morning, good afternoon, and thank you for having a world without cervical cancer. The fact is that every 2 minutes, one woman dies of cervical cancer in some part of the world. India appears to have the biggest burden of cervical cancer. And 1/4 of incidence and mortality appears to be in India. According to Dr. Sharda Jain, approximately 8 women die every hour and 1 woman dies every minute. It was a veterinarian, Georgius Papiniculus, who was investigating and looking after guinea pigs, who noticed the changes. And then in 1943, he proposed what is known as the Pap smear. And at least in America, it made a lot of difference. The fact also remains that if you gave the same slides to different pathologists, the agreement between the pathologists is around 40 to 50%. So the real advance occurred when Harold Hosson in 1984 found the presence of human papilloma virus in cervical cancer. He was awarded the Nobel Prize in 2008 for that effort. Papilloma virus is a DNA virus. It's a double-stranded DNA virus. There are about 223 different genotypes of papilloma virus, but 12 of them have been linked epidemiologically as high risk, that whenever there is the presence of these viruses, then these genotypes are associated with malignant lesion. The association for cervical cancer is virtually 100%, as well as for anal cancers. A substantial proportion of vaginal cancers also can be attributed to papillomavirus. A component of oropharyngeal, penile, and vulvar cancer is also associated with papillomavirus. High-risk human papillomavirus derived cancer has the greatest mortality and morbidity. This association is consistent, specific, and universal, making cervical cancer a highly creditable target for public health preventive efforts. The prevention can be primary by vaccination or secondary by early diagnosis and treatment. All over the world, genotype 16 and 18 have been found to be closely associated with cervical cancer. There appear to be another 10 more genotypes, but their association is less frequent than of genotype 16 and 18. As you see here, women bear the burden of cancer, of infection as a consequence of HPV, though more and more investigation of the role of HPV in men have also been carried out in the recent past. The HPV virus has a tendency to insert into human DNA. When it integrates into host DNA, it disrupts E2 open reading flame. This insertion of human papillomavirus into the human DNA leads to overexpression of two genes, E6 and E7, which are present in high-risk human papillomavirus. E6 will bind to P53 protein, which is a tumor protein, which plays a role in progression through cell cycle, while E7 will bind to retinoblastoma protein, which has affinity, which is a tumor suppressive protein. As a consequence of these binding of E6 to P53 and E7 to retinoblastoma protein, the normal death of cell is stopped, as well as there is proliferation of cell. So cancer results because E6 prevents death of the cell and E7 leads to uncontrolled growth. And together, these two genes which are present in high-risk HPV viruses cause cancer. This cancer appears to occur worldwide, but more in less developed countries. In the West, they have suggested that pap smear should be started by the age of 21, and every 3 years, pap smear should be done. That would mean that about 16 to 17 times a lady has to go and get the pap smear done. Of course, we know that early detection and appropriate treatment will prevent progression to cancer because it is chronic infection with human papillomavirus which will lead to cancer. But this strategy, which has been successful in USA and the West, does not work in India. What is required is that we have to think of both primary prevention by HPV, but ideally that should be completed before puberty or before the person becomes sexually active, or as secondary prevention by doing HPV testing. We need a sensitive method, and HPV DNA testing is much more sensitive than cytology. In fact, HPV DNA detection will detect 40% more infections than cytology will detect precancerous conditions. This can then lead to a simple algorithm that if HPV is negative, then nothing needs to be done for 5 years. While if HPV 16 or 18 genotype is detected, the person must undergo colposcopy and further treatment that is required to prevent the progression to cancer. On the other hand, if the other high-risk HPV positive samples, viruses are detected, then they should be cytology, and you progress as mentioned in this algorithm. WHO in their latest guideline also suggests that HPV DNA detection in a screen and treat approach starting at the age of 30 with regular screening every 5 to 10 years should take place. They do not suggest that normal persons should undergo treatment or investigation before 30 years because infection is very common, but human body has immunity to get rid of the virus at a younger age. After 30, if the infection persists, then it is more likely to be associated with cancer. In India, everybody talks about the role of screening and the burden of cervical cancer, and many publications have indicated what are the problems. The recent one I came across was by Satinder Kaur, in which she mentions that there's lack of awareness among doctors, especially about which test needs to be done. There's time constraint, cost of the test, and not sure which tests needs to be done. Those are the reasons that she found from her survey of the gynecologist, and from the patients. She feels that the patients don't get the test done because they're asymptomatic. There's fear of pain or discomfort. They feel shy, embarrassed, so not willing for examination, fear about being diagnosed with cancer. But unlike other cancers, which lead to frequent visit to the doctor, detection of cervical cancer at an early stage or detection of infection, which would lead to cancer at an early stage, can prevent the progression, and only one visit could handle the situation. There is a national health policy, but there is no comprehensive national screening program at present in India. So overall, there are two opportunities that we can use to prevent cervical cancer. One is to give HPV vaccination, and at least 3 different types of vaccinations are available. But I was told even Serum Institute of India is going to launch a vaccine which is going to be suitable for India. But today we will focus on the secondary prevention by early diagnosis of high-risk HPV and their treatment. Government of India has, of course, brought out their algorithm, and as with everything associated with government, it is complex and complicated and rarely followed. So a simple, but that the HPV detection will prevent deaths. The evidence was provided by Surya Narayan, who came to India from France in 1999. He went to Maharashtra, and there they had taken 131,000 women, divided them into 4 groups. One group also had do nothing, that is the standard of care. In the other groups, they were either doing VIA or cytology testing and HPV testing. 9 years later, when they came back and investigated, then they found that while there were 64 deaths in all the other 3 groups, the deaths in HPV testing group was half of what had happened in the other 3 groups. Their conclusion was, in a low resource setting, a single round of HPV testing was associated with a significant reduction in numbers of advanced cervical cancer and deaths from cervical cancer. Recently, WHO has also brought out about what are the technical barriers. They have listed that samples for breast samples have been used for collection of samples. swabs have been used for collection of samples, lavage and tampons have been used, and they have compared that of the various methods available. And I remember when I was in Port of Spain, we used to do VIA, but there you're looking for precancerous conditions, while by detecting HPV, you're looking for infection, chronic infection with a high risk associated HPV infection, which will ultimately lead to cancer. But this is much before cancer appears. Now we have many PCRs where we can detect 2 or more of the genotypes which cause cancer, and we are not restricted to digene only. In 2007, there was a paper which indicated that self-collected vaginal samples were equally effective as those collected in the clinic. There was a paper published by Neha Pathak in 2014 indicating in meta-analysis that urine could be one of the methods where we could look for the presence of cervical for high-risk HPV. Recently, after a meta-analysis of 15 studies, it has been indicated that accuracy of detection of HPV in urine for the presence of cervical cancer was as good as that of vaginal swab or cervical swab collected in the clinic. When we talk about urine, we are actually not, it's not the urine which is infected. What is required is first voided urine. I am a microbiologist, and whenever I want to test for urinary tract infection, I insist on midstream urine, which is on the second part. That means the first part is used to wash the external os, and the middle part of the urine, which will represent what is happening in the bladder. In case of HPV, it is the first part which we are using. That would mean that if you look at this, epithelial cells of cervix are continuously being exfoliated. Debris of epithelial cells mix with secretion from uterus, cervix, and vagina and accumulate between labia minora and urethral opening. Natural biological cleaning process of the genital tract is completed on urination, which flushes away the accumulated secretion. So the first part, first voided urine would actually represent genital secretion, and it is the first voided urine. 25 ml of first voided urine will contain the cervical cells, which will have the virus in it, and that can be collected in the privacy of a person's home and then transported to the lab for PCR testing and determining whether high-risk HPV infections are present or not. So the question then will be, would urine be an acceptable sample for HPV screening? Would it be acceptable by the Indian woman, by healthcare professionals, by decision makers? In Mexico, a study which we have replicated had investigated the effect of a preservative of DNA in the urine, because urine has enzymes which can destroy DNA. Then they have also investigated what should be the storage temperature, what should be the time between sample collection and DNA extraction, whether it should be first voided or convenient time, whether there was agreement between self-collected urine and sample collected in the clinic by a gynecologist, and whether cost, acceptability, and feasibility of urine was there. They had taken 5 volunteers, healthy volunteers between the age of 35 and 45, and they had taken 25, they had requested these volunteers to give 25 ml of urine in each of the 6 cups. 2 of them were without buffer. 2 of them had 10 millimoles of EDTA. 2 cups had 40 millimoles of EDTA. And they stored that at 4 degrees Celsius and 25 degrees Celsius. 25 degrees Celsius is normally called as the room temperature. And then it was sent to the lab for quantitation of the DNA. In the second experiment, they had taken again, the same ladies were asked to, the second was to find out how long the urine can be kept in the lab before the DNA is processed. And the first one, the final one was to find out whether first morning urine is required or any convenient time it will be collected. In the results, they found that the urine must be collected and transported in a preservative, which is 40 millimolar of EDTA. This will inactivate the enzymes and will preserve the DNA in the urine. Then it can be preserved at 25 degrees Celsius is better than preserving at +4 degrees Celsius. And as you notice here, it can be kept within it should be processed within 72 hours from collection of the urine in the lab. Within 3 days, it must be processed. When they simultaneously collected cervical sample and urine samples, they found the results were better by the urine samples than by cervical samples. So ideally, what is required is we should use 60 ml conical tubes, which will contain 40 millimoles of EDTA, 25 ml of urine, which is first voided without any cleaning of the urethra. That is what should be collected. It should be stored at room temperature or in gel pack and transported to the lab. In the laboratory, it will be centrifuged at 3000 RPM for 10 minutes. Then the pellet will be resuspended in 1 ml and a real-time PCR would be performed. This must be completed within 72 hours of collection of the sample. We all agree that control of any infection begins by early diagnosis, and ease of sample collection would hopefully facilitate the process, and many more persons would like to give their sample at the which we can collect from their home and then test. And I'm sure that once it is reported as having infected with high-risk HPV, they would seek advice and treatment from the gynecologist. Our report would indicate, as I said, our turnaround time, we had kept 48 hours as the maximum. The report would indicate whether HPV high risk is present or not present. And it will also explain that which are the high risks that we are seeking. And finally,
हर साल भारत में तकरीबन 1,23,000 महिलाएं सर्वाइकल कैंसर से पीड़ित होती हैं। तो अगर आप एचपीवी टेस्ट हर 5 से 10 साल में एक बार करवाते हैं, तो आपको इसके खतरे की जानकारी पहले से ही मिल सकती है। तो एचपीवी टेस्ट करवाएं और मेरे साथ करें, मैं कर सकती हूँ।
I thank you for your attention.
Thank you so much, sir, for that excellent deliberation. And we are thoroughly impressed by this new way of sample collection. Actually, we always think of, a collection of the sample by inserting a speculum and properly collecting it by a cytobrush or a swab. And yes, then we proceed forward, and we had that self collection of the sample or self sampling as well. So having this new way of collecting the sample for HPV infection, which can be the earliest way to detect the infection, and then screening and vigilantly following up that lady right from the early infection, and whether she's really continuing with that chronic infection, and whether she's now having the persistent infection by the high risk variety of this HPV. So all these things I think can be well monitored. I think that's a good suggestion, and I don't know how feasible and practical this is. So we would like to have your view. What is the efficacy of this, I would say cost efficacy of this way of sample collection?
So I think Dr. Ashok sir, because this has a convenience of, am I audible?
Yes, ma'am.
It's a convenience of a way of collecting at home and making it very scientifically, because HPV DNA collection is going on, and so the diagnosis will be almost perfect, and a little bit I think cost effectiveness will definitely be there. I think because HPV DNA testing is a little bit costly, but taking into consideration the effectivity and specificity, I think it may be the may mark the main investigation. Let's see. Let's hope for the best, and how the this our clinical oncologist.
Thank you, Archana. What I'm going to ask, sir, is the HPV infection per se is so common, and it subsides on its own spontaneously. That is what we have been, saying over the years. So if it is persistent infection by these high risk group of HPV, which lead to the lesions which are high risk, these are the women, they only need to be followed up. So do we have any advantage of collecting this urine sample, which only tells you about the infection? That is what my question is. Over to you, sir. Thank you.
It will tell about all infections. In fact, there's another group which works on STDs, and they have been also saying that same samples could be used for but that's a different, could be used for gonococcus, for chlamydia, and for mycoplasma investigation. But the point is that since we have about 600 to 700 phlebos with us, any part of India, we can collect the sample from their home. So, booking can occur by just giving a call. Once a person is diagnosed to be suffering from a high-risk HPV, I would not expect anybody to sit at home and not seek advice. Either we need to educate the father, the husband, as well as the children, because I find the children are more motivated to get one thing is the starting point is our ladies do not want to go and get pap smear done. In any family that I've talked about, they don't seem to be very keen on getting pap smear done. And that is why the cancer is not detected in time.
No, sir, I think, sorry, sir, to disturb, what I think the main specificity here is their directly strain where you are taking out the strain.
We are detecting all viruses, and whether the aim is whether 16, 18, 31, there are 12 viruses which epidemiology has been linked with cancer. If these infections are there, then chances of cancer are more. There are 223 three different genotypes. All will be detected, but only the high-risk ones will be communicated. So our aim is to decrease anxiety, not increase anxiety. And that is why we are saying that we should not test below 30 years of age, because below 30 years of age, infections may occur and the lady would be able to get rid of infection. It is persistent of infection which will result in cancer.
Exactly.
But
That is
my
what-
question is, what is the cost of this test?
Ma'am,
Because
we
in
had
India,
that,
cost is very important.
we have been having that discussion, and as you know, we just come out of COVID. In COVID, when we started, that was also PCR. PCR we started with 4,500, and finally it came to 450. Right?
So COVID was very different. COVID was,
cost-
there's an immediate death. Everybody was worried. Everybody was going for the COVID testing, but HPV is very different.
they are not worried.
Sir, there are so many things. You are only working for specific people. We are working for the general population, because you have to go for the diabetes also, hypertension also, thyroid also, and number of diseases are there. So we have to screen for each and everything. That is going to cost a lot to the patient. So whenever we say this test all the time, the cost factor is very important, because if the patient is having money only, then the patient can go for that. And that too only the screening.
Ma'am, yes, I think what it does is that once a person is negative for high-risk viruses, then for 5 years, nothing needs to be done, at least as far as cervical cancer is concerned.
So right now, what is the cost for the test?
Cost we kept as 1,500.
So 1,500, because for a general population, the basic income of the family is around 25 to 30,000 per month. And there are at least 4 members in the society. So spending for them is 1,500 for just for the diagnostic test. I think when we go for a whole population, we have to think about the cost.
No, cost. And of course, I know we've had that even with Dr. Shadaj, and the first question was that why the cost cannot be the same as for COVID. Then I asked in between we had an internal discussion. They said, if we have it depends on the number of samples. If the samples are going to be few, then naturally the cost has to be.
In our city, we can get a pap smear done only in 300 rupees. So it's better to send the patient for the pap smear.
I've already shown you the paper which was published
I think
in JAMA.
only in the high-risk patient, we can go for both the tests.
Ma'am, I guess I'm not a financial person who can come with this. I can only suggest that the method is available. And I thought one of the drawback was.
Sir, she is also okay, because in India we are planning for 90, 70, 90, and still we are lagging behind so much. There's hardly 3% of screening going on. Hardly there are 5% vaccination in adolescent going on. So they are much worried about their looks, and they can spend any amount on their clothes, dressings, and everything. But still, we need to tell them what is actually important for their health. Because even here, my main aim is to make them aware. At least when the people are aware, then they will do. Because suppose that we are sitting in a city, if there's somebody comes with what is the best test for me, so like for the baby, majority comes with a direct ultrasound. हमने अल्ट्रासाउंड करा लिया, अब हमारा सब कुछ ठीक है. They are least bothered कि उनको GDM है कि नहीं है, उनको hypertension है कि नहीं है. It is none of their business. So they say only thing ultrasound. If ultrasound is okay, then mother is okay, and the fetus is okay at that particular time. So that is this difference we have to know. We have to, at least we clinicians need to know how much cost is going to be on treatment, and how much anxiety is going to be there, and what we can do for our patient. And at least we know, because at once 20 years back, nobody was doing level 2 ultrasound. Nobody was doing this double markers or quadruple markers. Now each and every patient
was not done, madam. Anti-scan was also not done.
No, so but the things are there now. The patient are getting, and now it is your responsibility also. आपने कॉपर्टी लगा दिया, फिर पता चला 4 years बाद उसको कहीं कोई malignancy diagnose हो रहा, she will say कॉपर्टी लगाया था डॉक्टर ने, उसी से हो गया है हमारा सब कुछ. इन्होंने, she forgot to do the pap smear, she forgot to do the HPV testing. So these few things are in gynecology, at least as in obstetrics, we need to know how important are the antenatal profiles and ultrasound. So we need to know what best we can offer to our patients. I think this is a good idea, and we will again discuss and with all these our esteemed experts, because Dr. Kavita, she is also in CMC Ludhiana, and she is doing so much of work in that medical college and all. And so, and the Priya Ganeshan and this Sneha, she is doing wonderful job. So we will, I think these experts we will again do, and then when we will come up and we will be taking, because your talk is mind opening and it was very nice, because this collection at home, without any much ado, this urine sample, we need to tell them that this sample is available. I think half of their problem is gone because they are getting it done at home only and sample collected. So if we can do that, and if it is advisable and it is in guidelines also, so everybody will be following, I think. So because the seniors has to take this thing.
And the price will fall once this test.
Price, yes,
exactly. I was talking about the same, that whenever you have some new either equipment or a medication, the cost is always high, because the whatever they have invested in the research, the time and the finance. Initially, when the requirement is less, or they have to just launch the product, it's high. But when you have proven safety, efficacy, and the demand goes high, definitely the cost also comes down. That is what I was about to say, that initially, if not something, at least as we are saying, VIA, VILI, and of course the pap smear, whether it is a routine pap or a liquid-based cytology, LBC, at least something should be done, as we have been following. Even the FOGSI says 21 to 65 years, that is a period you should screen for cervical cancer. And yes, even post hysterectomy, we should continue to screen. Even from the vault, we should continue to scrape and send it for the examination. But I think, sir, this is a way forward investigation. What I was saying, that yes, pap smear, LBC, and then the self-sampling. Definitely urine sampling is beyond that. People who are, they're not even able to collect their own sample for pap smear, they can also get themselves tested. And as I said, that if at all you find that they are infected with a high risk strains of HPV,
that is a very important.
That guides you that yes,
it's different from pap smear.
Yes, so it should be, that is a lady who should be followed up for, she should be stringently monitored. I think that should be.
As Dr. and Sir said, if she is negative, suppose, then she is free for 5 years.
Yes.
So she can, so that those 5 years at least she can take care and everything. When vaccination, of course, everything. But at least we know that she will be there free for 5 years. And if it is so even in the COVID, when the vaccine was free, nobody was taking, and in states and all, they were paying so much, and they were running for vaccine. In America and all, what the scene was opposite. Here in India, the majority was just denying, even if it was free, and it was, then they have to, all the medicos had to get vaccinated first, and taking selfie and putting on all social media. We have taken, we are not having no problem. See our selfie, I just got the jab. So we were doing all sort of thing that, so if acceptability is always low, there's always a denial at first, even if they are diagnosed. Dr. Kavita is there now, she will.
Ma'am, you're very right, because when COVID started and we were asked to take the vaccine, so I was pushed because being the head of the department, everybody said if you take the vaccine, then the rest will follow. So I was the first one to take the vaccine. So whenever anything is brought new, always there are some problems, apprehensions will be there.
Apprehension, yes.
Yeah. And there's one, just a comment from my side, that there's a cervicovaginal self-sampling kit also, which is available. And there was a ROSE trial which was done somewhere in Malaysia, where they have made a roadmap for eliminating cervical cancer in their country, in Malaysia. A model has been made where the women are encouraged to get self-sampling from home, and these kits are provided at home. So they do a cervicovaginal self-sampling this thing kit and send it to the laboratories for HPV testing. So I don't know whether it is being done in India, but I think there was a company based somewhere in Mumbai who's also promoting this cervicovaginal self-sampling. So that reduces the obstacles the women face because they don't come to the hospital for
I think some facility kind of thing was there.
Yeah. So these things are happening, and it will be very good if we can provide these kits also. But cost is an issue because even for pap smear, which is same 300 in our institution as well, people don't come forward and get screened. And I think we need to educate more into the remote areas and other women that they need to be screened, because even I find in our hospital, the healthcare workers also, many times nurses, paramedics, they don't get screened. So we have to educate that way also.
Yes,
Just
medical
wanted
and
to ask,
paramedical both. Once we asked in our society about 10 years back, how many of you got that pulse speculum done or pap smear done? None.
That's the reason, if you remember, Dr. Archana, 2020, we, myself as breast committee chairperson, we have done a huge comprehensive healthcare camp for the ASHA workers, saying that this is the basic unit of our healthcare system. And if they are taking care of our health of the country, who will take care of their health? That is what the initiative by me. And for this entire district of Yavatmal, we had 2,500 ASHA workers screened, right from complaints, pulse BP, everything, and pap smear, mammography, ultrasound, everything was done. And it was a huge camp in the tenure of Dr. Nandita Palshedkar, where we came
Yes,
up.
sir, we have to see how can we collaborate this into at least in talks and all, so that later on it can be picked up very nicely. So
I wanted to ask Dr. Ashok, sir, whether we have done any comparative study of this self-sampling by urine and compared to self-sampling of cervicovaginal and pap smear.
One, as I said, what was done in Mexico, we've tried to reproduce to see that, yes, the parameters are met. The second one was getting samples of those which were diagnosed as HPV positive. They getting the urine, but we've had very few samples collected because we do get a number of samples, but very few of them are positive. And those which were positive, we did collect from Dr. Sharda Jain's clinic, and 3 of them which she sent were positive. So it's not very many, and so we've been, because
so we need larger number of
that is true
population and
to confirm that the parameters that have been listed will work. So you do need EDTA preservative. You do need at room temperature. It must be processed within 72 hours. Those parameters are there. But along with that, those which are those of the ladies who were positive were confirmed to be positive using urine, sir.
So maybe, sir, in near future, you can include many of these hospitals, institutions,
yes,
and
I think it
do
was
a
just
bigger trial.
That is there. We do feel that the ease of sampling, of course, one is that I was looking at the cost of vaccination. One is that the vaccination must be there before the exposure. That means vaccination must be completed before the person becomes sexually active. I've heard about catch-up vaccination, but I think there is no scientific basis of it, because the virus integrates into the DNA. Once it is inside the cell and it has got integrated into the DNA by the first infection, if you take vaccination, it's not going to come out in the circulation. It is from contact from one cell to another cell, it passes on. So as a consequence, vaccination has been shown to be effective provided it is vaccinated before exposure.
Yes, sir.
And
Ideal time for vaccination, they say, is before sexual exposure. But why they recommend a catch-up and even vaccination up to 45 years, what they say is that the HPV vaccine, though it is not therapeutic, it is mainly prophylactic, but will at least prevent infection with other strains. So not necessary that one strain and all the strains the patient will be infected with.
but as you know, the CERVIX vaccine has only two viruses.
16 and 18 are the most.
Cardinal vaccination has either 4 or 9. And we are listing that at least 12 genotypes can cause, are associated with high risk pregnancy, a high risk of cervical cancer. So, of course, that is there, that sometimes these answers are very difficult, because overall the proof will lie in prevention of cancer, which will occur 20 years later. We must finish vaccination by 15 years, and if a person passes the youth without suffering from cancer, then we know that it is there. And now, of course, the vaccinations have been there in many countries, and they have shown that the prevalence of cancer has decreased, but the need for testing continues. So just because a person has taken vaccination, it doesn't mean that that HPV should not be tested. So the testing need will continue. I understand the cost is one of the factors.
So
Now that
sampling with urine sample will continue even after vaccination.
Yes.
That is
in the same manner, for 5 years or for the longer duration in the vaccinated patient?
Same.
Every 5 years, we have to
five
every
years
5 years.
Yes,
Same protocol.
From
protocol
whatever
for the vaccinated and non-vaccinated patients.
Yes, ma'am, because in vaccination, as you know, vaccination should be completed by 15 years of age, and vaccine will be either two genotypes, or 4 genotypes, or 9 genotypes, but there are 12 genotypes which are associated with cancer. So the risk of those which are non-vaccinated genotypes may still cause cancer. So
now that we have come up to monovalent, I think why not to come up with the 12 valent, so that all the strains are getting covered. So then, is it feasible?
Yes, I think
every time COVID की strain बदल जाती है हर बार.
These are more stable. DNA is more stable because they have proofreading facilities. So if there are mutations, then proofreading gene will chew them up. And RNA is more prone to mutations.
Okay. Dr. Monica, what you were asking, I just wanted to put in my words that even after vaccination, you will follow the same protocol. If you do with pap smear, you have to do it every 3 years. With HPV, you have to do every 5 years. So that same protocol, even after vaccination, needs to be followed up.
I just want to. I remember Dr. Kavita, Sneha, and Yashodhara. I think when we were PGs and doing, I think about 20, must be more, 30 years around. 35 at that time. This empty pill was this RU486 was trial were being done, and so many our friends were doing thesis. So we used to laugh. How come this that name was RU486? So then later on, after that, it came to market after almost 20 years. It took so many trials in medical colleges. So, sir, I don't know how come then if it is really how can we write? That is a main thing. I think we have to discuss that if we are prescribing something. So suppose I tomorrow I write for this HPV urine sample collection. So like I have to prove what is from where and how useful it is. That is the only thing in my mind, I think, right now.
No, as I did mention that there were two meta-analyses, one done by Neha Pathak in 2014 and then in 2021. And there's a 2023 publications also about talking about alternative methods of collection of sample.
Okay, thank you, sir. We have that. We will be talking more and more. And thank you, everybody. And any expert want to say anything, you are requested to say something, and then we will close the. And thank you to the Haridwar Society. Thank you so much.
Thank you, ma'am. Thank you for the opportunity.
Excuse me, as I join
Thank you, ma'am. Thank you, ma'am.
Thank you so
Welcome,
much.
Dr. Yashodhara.
And thank you, Yashodhara ma'am. Hi.
Hello, ma'am.
Nice to see you all. Vita.
I just want to say
ma'am, very informative.
Vaccination doesn't mean 100% cure. We must keep in mind. That's why screening should go simultaneously. That's why screening should go continue, or there may be chances that suppose we have given vaccination at the age of 20 years. It's not ideal that everyone will get the vaccination by the age of 14, 15 years in our present circumstances. So she may already have been infected with one of these strains. So that's why screening is very important to detect the pre-invasive lesions. That's why WHO, जैसे सभी को पता है, ये तो वैसे 90-70-90 प्लान यही है कि हम 90% वैक्सीनेशन करें, 70% केसेस में हम हाई क्वालिटी स्क्रीनिंग प्रोवाइड करें. अब हाई क्वालिटी स्क्रीनिंग क्या है? प्रैक्टिस में हम सालों से कर रहे हैं, लेकिन इसके बावजूद भी हम बहुत अच्छे से प्री इन्वेजिव लीजन्स को और कार्सिनोमा सर्विक्स के इंसिडेंट्स को कम नहीं कर पा रहे हैं. तो हाई क्वालिटी स्क्रीनिंग का मतलब बेस्ट तो ये है कि हम एचपीवी जीनोम को डायग्नोज करें. और इफ वी आर ऑप्टिंग फॉर साइटोलॉजी, then we need good cytologist and good reporting, of course. And so ye certain important point.
Yashodhara, you came late actually.
Yes, I came late because of being HOD.
We will show you recording and then you gave your comments.
Yes.
And then we will be very happy. She is from Medical College Gwalior and very renowned. She is working hard for cancer screening, cancer prevention.
Thank you, ma'am. I know that most of the things have already been discussed, but
and she is President MP State Chapter AGOI.
Ma'am, we would like to thank all the experts who were present with us. Dr. Sneha Bhoyar, thank you so much for joining in today. Dr. Vidhu Modgil, thank you, ma'am. Dr. Monica.
She's going to be the next public awareness chairperson. So she'll be very helpful. And Dr. Vidhu Modgil, we know she's from Punjab and very dynamic person.
Yes.
She will take screening very seriously. And Monica Gupta is from Rajasthan and Alwar. And she's a wonderful worker and really, really interested in doing the camps and screening. She always keep on doing. And Kavita Bhatti, our favorite, she is from Punjab, Ludhiana, CMC Ludhiana, and she's doing wonderful work for this in oncology and doing so much of teaching and workshops and all.
Thank you, ma'am, for that favorite word.
Thank you, everybody. Thank you for joining.
I'd like to take permission from you and showcase a few of our brands. Lycored from Jagsonpal, ultimate cell protector containing 100% natural lycopene with phytonutrients. Lycored soft gels, which is a very well-known brand. It also has anti-oncogenic properties. Do consider Lycored for your patients. There are more than 35 clinical trials and 56 publications with the Lycored soft gels in India. Jagsonpal being the progestin people, we have all the progestins available with us. Natural micronized progesterone in the Divagest range. We have progesterone sustained release tablets of 200 mg and 300 mg. Vaginal soft gel Divagest 200. And then injection Divagest 100 mg. We also have dydrogestrone 10 mg, micronized dydrogestrone as Divatrone. Maintane 17 hydroxyprogesterone caproate 250 and 500. Maintane tablets of 5 mg allylestrol. We also have norethistron in controlled release, also plain. Cyclorec and Cyclorec CR10. Then we have Dynagest as Endorex. So just reminding you of our progestin range. Hope to see you all again and thank you all very much.
Thank you so much, Haridwar Society. Thank you so much